Welcome back, ladies and gentlemen. We now begin Symposium 9 in Whole A, focusing on obesity with insights into fat storage in adipose tissue, pharmacotherapies for obesity, and optimizing outcomes of metabolic and bariatric surgery. I'm delighted to invite our chairpersons, Dr. Darshani Karuppiah and Professor Ranil Jayawardena. May I now invite our chairpersons to introduce the speakers and panelists for the session.
So, good morning, everyone. And we are deeply honored to have distinguished speakers from the international forums as speakers, as well as 3 panelists for the panel discussion. And as you know, obesity has become a global problem, and Sri Lanka also not the exception. We also have a prevalence of obesity, 35 to 50%, depending on the cutoff we use. So it's probably the main public health problem in this country, which, as you know, it's lead for all these metabolic and psychological, economical problems. So this symposium very complete. We start with probably pathology, metabolic medicine, and how this fat distribution in the upper body, lower body, so you will learn something new, and followed by the endocrinologist, but pharmacology management. Then finally, for some obese patients need a surgery, so we'll complete the bariatric surgery session also. In addition, there are three speakers from Sri Lanka. They also cover the endocrinology and clinical nutrition as well as surgery. So I'll hand over my co-chairperson to introduce the first speaker.
So I'm delighted to introduce our first speaker, Professor Fredrik Karpe. He is a physician scientist at the University of Oxford, and he's graduated and trained in medicine and did his PhD at Karolinska Institute, Sweden. His topic today, targeting fat storage in adipose tissue. Professor Karpe, it's over to you.
Thank you so much for this kind introduction, and I'm immensely grateful to be here at this very educating symposium, broad-ranging, and I've really enjoyed every second since I arrived. So I will take the opportunity to point out a little bit about basic physiology and obesity in metabolic medicine of obesity. And what the focus of my talk will be targeting fat storage in adipose tissue, and that seems to most people as a title as something self-evident. But I think it's still not explored enough and not understood, and perhaps in particular not thought of as a target in terms of treatment for the future. So I think I'll start by going back a little bit to metabolic flux models and understanding where the fat comes from, where it goes, and how the human body is storing fat in particular. So we have the diet, and in a typical Western diet, we would have about 100 grams of fat, triglycerides, in a day. That enters the bloodstream, and the presence in the blood is very transient, and at any given point in time there would only be something in the range of 3 to 30 grams present in the blood. And the route from the blood is then to either store in adipose tissue, and the flux in and out of that is of course quite big. So in a given day, if you think of the meals we eat, at least half of that will be immediately stored in adipose tissue in the postprandial period, 5 hours after a meal. But then that repository, the adipose tissue, is then giving back the fatty acids when needed in the fasted state. So then there is another organ of essential importance, and that's the liver. The liver will take care of the remnants of what is not taken up by adipose tissue, and it will convert that into very low density lipoproteins and resecrete that into the plasma triglyceride compartment again. And I will dwell much more about the plasma compartment in my talk tomorrow when I talk about management of triglycerides in the blood. So the rate-limiting step for uptake of the triglycerides from the blood into the tissues is a lipolysis-mediated step conveyed by lipoprotein lipase. Lipoprotein lipase was discovered 60 years ago, so it has some time to be characterized, but interestingly, we still don't fully understand its regulation. It's only in the past 6 years the actual discovery of the set of inhibitory proteins of lipoprotein lipase have been discovered. And I'll mention a little bit of that in the end of my talk. So let's now move over to methods to actually study adipose tissue fat storage. And I think here is the crux in why so little has been known about it, because as you see, this is a complex way. You need complex methodology to actually measure this properly. So the very first ever attempt to quantify the fat from a meal and how that ends up in adipose tissue was conducted actually in Sweden by Per Morin and Per Björntorp's group. And they had a heroic experiment where they have a large quantity of radioactively labeled olein that was ingested orally. And that was followed by multiple biopsies of adipose tissue to see what the radioactive enrichment was in the adipose tissue biopsies. And you can easily understand that such an involved way of analyzing a transport route is something that you can only do once, and because of the large radioactive load required, it's not easy to repeat and possibly not safe long term. Similar types of approaches have been used by Michael Jensen, but that has always involved intravenous infusions of fatty acids. And as I mentioned in my previous slide, the entry of fat into the adipose tissue is through lipoprotein lipase and triglycerides. So infusing a free fatty acid is not providing the right vehicle to actually study fat storage. So those studies have to be taken with a little bit of, with a pinch of salt. So more modern studies, for example, metabolic imaging using PET-CT, for example, has its challenges. There is actually no available compound that is radioactive and suitable for PET-CT that is contained in a triglyceride. It's only in fatty acids. So those type of studies have not successfully measured fat storage as we would like to do. And I'm coming now to the very end of methodologies to accurately measure fat storage. And that's a technique that myself and my colleague Keith Frayne have set up in Oxford a couple of decades ago. And that requires arteriovenous cannulation to assess human adipose tissue in vivo, and I'll come back to that later on. That enables quite a broad profiling of the tissue, not only the fat going in and out, but you can also measure lactate and glucose and glycerol and all the other compounds that could be of relevance for the actual characterization of the fat storage process. So just show you some principles behind the really groundbreaking study by Morin using the large quantity of radioactivity. So you see here the biopsies he took from abdominal and femoral adipose tissue. And it's a very clear message here that the abdominal tissue seemed to be much more active in taking up the dietary fat immediately. And the femoral tissue is a little bit more quiescent, so less radioactivity ended up in the femoral tissue. And this was actually replicated 13 years later by Michael Jensen using a very, very similar technique adopted from Maureen. And again, if you look at the comparison to the right between the upper body and the lower body radioactivity trapped, you see that the upper body has a massively more radioactivity contained in the tissue after administering the fatty acids orally. So that replicates and really tells the same story. So I'm now turning over to the concept of these two tissues behaving very, very differently, the upper and the lower body adipose tissue. Those two tissues, as we know, have different associations with metabolic health. The upper body pear-shaped adiposity has all the risk factors for diabetes and future heart disease, whereas the lower body adipose tissue and expanded lower body adipose tissue has a paradoxical, highly interesting negative association. It actually seems protective to have large hips, the typical female body shape. So the complexity of that system needs to be illustrated in my first slide. So I've now divvied up the adipose tissue into three different distinct compartments, the upper body, the lower body, and I've also stuck in the intra-abdominal fat, the visceral fat, as a separate compartment. So one of the questions I will dwell on from now on is really to characterize the fat storage into these different organs and how that could actually explain some of the features of upper and lower body adiposity and how the metabolic preference for lower body adiposity can explain whole body metabolic health. So let's start off by looking into the actual system we are trying to characterize here. Here's a cartoon of adipose tissue perfused by a capillary. The little red dots lining the endothelium is lipoprotein lipase, the enzyme that is rate limiting for uptake of the triglycerides from the triglyceride-rich lipoproteins in the blood. And imagine that we can take a blood sample of the blood going into the tissue and then take a blood sample of the blood coming out of the tissue. And that is exactly what I'm going to illustrate in the technique I'm going to talk about from now on. We can actually measure the actual rate of uptake and the rate of storage, the rate of release of fat from the adipose tissue in vivo in humans. The technique that we use for this is the classic arteriovenous difference technology, and the favorite vein for the upper body is the inferior epigastric vein that can be cannulated, and with a cannula inside and a simultaneous arterial cannula, we can look at the arteriovenous difference across upper body subcutaneous adipose tissue. A very similar type of technique was developed a little bit later by one of our clinical fellows, Siobhan McQuaid, and that simply describes the arteriovenous difference between the saphenous vein and the artery. The saphenous vein, and we characterize that very carefully, is draining the subcutaneous tissue. In a venous competent person, there is no contribution from deeper tissues, muscle tissue, etc. So it's actually really a clean sample of subcutaneous tissue. So the technique that we used for this arteriovenous difference study was the first published paper on that is now over a decade old. And that in that study, we actually had an in vivo labeling of the fat coming out of the liver, the very low density lipoprotein triglycerides. And we achieved that by infusing a fatty acids systemically into the human body. And that would then go to a free fatty acid would then go to the liver, be esterified into VLDL and come out endogenously labeled. And then we also gave an oral load of a stable isotope labeled fatty acids, labeling the chylomicron pool. And in this study, we had the arteriovenous difference set up, established, and I'll show you one result slide from that. And this is showing the chylomicron triglyceride uptake on the y-axis a long time after the meal intake in abdominal and the gluteal tissue. And you see the area under the curve of the abdominal is twice as large as the gluteal. So this is actually saying exactly the same thing as Per Morin did with his radioactive study 25 years earlier. The abdominal tissue has a propensity to take up dietary fat very effectively, very quickly. So if we then turn to the other source of fat that can be stored in adipose tissue, the triglycerides arising directly from the liver, the VLDL triglycerides, the picture doesn't look quite the same. Here you see that the area under the curve of these two are actually almost the same. Compared with the abdominal tissue or the chylomicrons, we now see that there seems to be a preference for the lower body fat tissue to actually take the fat coming directly from the liver. And with that, we actually postulated that there is a direct route for liver-derived fat triglycerides for storage in the gluteofemoral adipose tissue. And if we could enhance that pathway, we could also target both diabetes risk and cardiovascular risk by offloading liver fat, reducing fat content in the liver and NASH eventually, and also improving the lipid profile. So to further this and actually gain more absolute evidence for this pathway, we started off by looking at pilot data generated in the unit. And you see here, again, the labeled VLDL triglycerides over a meal period comparing abdominal and gluteofemoral tissue. And at time 0, the gluteofemoral tissue is a bit quiescent, but in the postprandial period, the actual fractional extraction of the VLDL is going up and is staying up, whereas the fractional extraction in the abdominal tissue is flat or going down. So the area under curve for trapping VLDL triglycerides into the gluteofemoral tissue seems to be there. The final test is something that is ongoing, so I can't show any data on that. And this is a small bespoke study where we actually recruit people according to their upper body preponderance or their lower body fat preponderance, and using exactly the same algorithm as before. And the hypothesis here is that fractional extraction of VLDL triglycerides is greater in the gluteofemoral fat than in abdominal, and this is augmented in people with lower body adiposity, the safe and good adiposity. This study is actually conducted by my absolutely talented and wonderful Sri Lankan fellow Harsha Dissanayake, who's with me right now and is doing this as his DPhil in Oxford. So this is the background of these fluxes. So I'm now turning over to something that has a little bit more immediate clinical relevance. And that is, first I'll illustrate it by showing you the archetype condition when you can't store fat at all, in particular in the lower body. And this is a condition called familial partial lipodystrophy type 2. The picture illustrates the legs of this young woman who is affected, and you will see in these legs that they are completely fatless. The legs does not look like a woman's legs, they are more like a man's leg. And she has some of the very typical signs. On the back of a calf, you would actually see a vein standing out, the phlebectasia, we call that sign, which should not be seen in a woman's leg. So carriers of this gene mutation in LMNA have a multitude, very severe syndrome with extreme insulin resistance. These are patients where you see signs like acanthosis nigricans and skin tags. They have invariably early presentation, very early presentation of type 2 diabetes. They have hypertension. They have always hypertriglyceridemia. They have fat accumulation in the liver. and very early and high risk of coronary artery disease. This woman, 29 years old, had triglycerides of 7 millimoles per liter. That would be more than 700 milligram per deciliter, and borderline raised glucose, ALT raised, and in particular, she has had mini strokes and TIAs on several occasions already at the age of 29. So this is a condition that is rare as hen's teeth. I think in the UK, there's probably a very large unknown number, but we are aware of about 100 patients. I have 20 of them in my lipodystrophy clinic in Oxford, but they are not detected and require a genetic diagnosis. But there is clearly a commoner variant of this in the population as well, because we have people with these features who we send in genotyping for, and they come back, no, patient does not carry the LMNA variant, and that comes in more than 9 in 10. So this is common. So there must be another, presumably polygenic variant of partial lipodystrophy. And that is something that has been named familial partial lipodystrophy type 1, a very poorly characterized syndrome, but it's assumed to be polygenic, but the polygenic background to this syndrome is not known. So a talented postdoc with me, Dr. Atabaki Pastar, and myself, we decided to look a little bit deeper into the genetic background of this syndrome, or try to see if there was a polygenic signature for this syndrome. And the way to do that was to go for the archetype phenotypes that these patients have. And I've named them here: waist-hip ratio adjusted for BMI. So they should have a very low waist-hip ratio, no lower body fat, but all fat in the upper body. They should have insulin resistance, and they should have raised triglycerides. So here are 3 phenotypes. There we can use existing data from genome-wide association studies to actually find variants that could describe this. But the trick here is to not go into these studies directly. Instead, demand from these studies, or the results from these studies, that the genes that are contained as genome-wide associated SNPs for the various phenotypes are actually coordinates between the 3 phenotypes. So if we look at giant, waist-hip ratio, and MAGIC for fasting insulin, and the GLGC consortium for triglycerides, and then we take one step further and require that all the SNPs from MAGIC and for fasting insulin and triglycerides are directionally concordant with waist-hip ratio. And the same thing for all the fasting insulin SNPs describing insulin resistance. They have to be concordant or directionally consistent with both triglycerides and waist-hip ratio. And finally, for the triglyceride SNPs, we require that those ones are directionally consistent with those from waist-hip ratio and fasting insulin. So this becomes a multi-trait SNP approach to describe a syndrome. And in order to give similar weight to all these SNPs that are found here, we used a better definition of fat distribution using DEXA scanning. And the best one for fat distribution and lipodystrophy is to have the ratio of trunk fat mass over leg fat mass. We call that fat mass ratio. So all these SNPs were then concordant and filtered for fat mass ratio to get similar weight, and filtered further with clumping, shrinkage regression, and we ended up with 80 SNPs that describes this polygenic feature of familial partial lipodystrophy 1. And these SNPs actually ends up in genes. If you do co-localization, you end up in genes that have never been described before. So there's a lot of novelty here as well. So you can then take these SNPs and use them in a polygenic risk score. And here is the performance of this risk score in the UK Biobank. So if you look at the 10th decile, the one to the most to the right, the very steep curve, you see that there is a really very good description of fat mass ratio using the polygenic score. So the polygenic score works for its intended purpose. You then take the polygenic score and look into the UK Biobank for incidence of cardiovascular disease. And in the short follow-up that we have in the UK Biobank, but it's still quite impressive numbers, there is a highly significant increased risk for cardiovascular disease using this SNP score for the FPLD1, really showing what we expected and I'm very pleased to see. So I'll now finish off a little bit by focusing on actually one gene target that happened to be the strongest one in this polygenic score as a kind of thought for the future of how fat storage could perhaps be augmented. And the gene that I'm talking about here is a gene that you probably haven't heard much about. It's ANGPTL4. ANGPTL4 is actually the natural inhibitor of lipoprotein lipase. So we go back in full circle. This was the rate-limiting step, and here's the natural inhibitor of lipoprotein lipase. And this gene has a very interesting coding variant that is quite common. And that's probably the reason that it just came into to the selection of SNPs relevant for fat distribution. So you see here in our own Oxford Biobank, impact of carrier status where of about 2.8% has an impact on triglycerides, lower ApoB. You look at leg fat, more leg fat. If you look at android fat, the upper body fat, you have a less android fat if you have that dysfunctional ANGPTL4. So dysfunctional ANGPTL4 will give you more lipoprotein lipase action. So my final slide here is really seeing, can this be used for the future? And you can use the ANGPTL4 gene variant, as I showed you, and do your in silico genetic study using Mendelian randomization, and that comes out highly positive. What hasn't been done is to use a monoclonal antibody against ANGPTL4 as a drug and see the effect of fat distribution. But genetic data suggests this would work. And another drug that is under development seems to be doing exactly the same thing, FGF21. Interestingly enough, all these drugs are actually now under development. So this is my summary slide. I think I've been fairly clear all the way through, so I skip reading it out, and I would be very happy to take any questions now or afterwards in the discussion. Thank you.
Thank you very much, Prof. Karp, for the very interesting topic. It shows how very little we knew about the adipose tissue, viewing as just inert storage, shifting to a complex organ, targeting various pharmacotherapy. Thank you very much, Prof. Karp. Now I would like to invite my co-chair to introduce our second speaker.
Yeah. Our second speaker is Dr. Nitin Kumar. He's not a new person for Sri Lanka. He has been visiting Sri Lanka. I think he was in Sri Lanka for the last month or so for the Endocrine Society sessions. And his topic is evaluating landscape of pharmacotherapies, obesity. In personal note, he's a very active expert in obesity in the South Asian region. And he founded the South Asian Obesity Forum. So I think he will share some new knowledge for the physicians, which is very important. Over to you.
Thank you so much, Dr. Ranil, for that very kind introduction. And right at the onset, I'd like to thank Professor Prasad and the entire organizing team for having me here today. In the next 20 to 25 minutes, I'll take you through this topic on the evolving landscape of obesity pharmacotherapy in clinical practice. And I thought I'll delve into this topic by briefly covering 5 domains, very briefly. The 5 domains, the first one being what is the need for newer pharmacotherapy for obesity? What's the relevance at this point in time in our day-to-day clinical practice? We'll talk about the different targets, the evidence that is available for the previous and the current drugs that are now increasingly becoming available in the South Asian region as well. We'll look at how much is the impact of these drugs. At the same time, we'll also discuss how these drugs are not only reducing fat, but what is the impact of these medicines also on muscle mass, which is again something which is very relevant to our part of the world in our population who already at baseline have lower muscle mass. And we'll talk about the indications when we start, how we monitor these patients when we start these patients on therapy. And last but not the least, we'll also talk a little bit about some evolving literature in terms of drugs which target specific genes. So let's get started with the first part, which is talking about the need of these medications. And I'm sure all of us in the audience agree that obesity has become like a pandemic globally, as well as in our region, in our different countries. When you look at specific data from the South Asian region, the World Obesity Federation has made it very easy for us to compare different countries with respect to their obesity status, because now it gives a national obesity risk score for each country, for adults as well as for children. And what we see data is it is very similar for countries like India and Sri Lanka, both for adults and for children. It is indeed rapidly increasing. When we looked at our own data from the National Family Health Survey in India, this was National Family Health Survey 4, we found that about 35 to 40% of the Indian population was overweight or obese. But just in 5 years' time, when we moved on to National Family Health Survey 5, whatever was in late 30s has now become early 40s. So definitely, obesity is increasing very rapidly. To add to the problem and the complexity is our own phenotype, the South Asian phenotype. We know that we tend to have much higher quantum of body fat for a given amount of BMI. We know our waist and visceral adipose tissue. We heard a brilliant lecture by Dr. Fredrik Karpe how the visceral fat, the upper body fat, is the bad fat, and we have it, unfortunately, much in excess. And we also have this unique phenotype that we talk about, wherein we may have people who've got normal BMI, but a high body fat, normal weight obesity. And more recently, in the last time that I was here, we presented data for a 10-year follow-up of what happens to people with normal weight obesity. So all this data, all this statistics does sound quite disturbing, but the good thing is our understanding of the disease, our understanding of obesity has also improved remarkably over the years. No longer we consider obesity just as a blame of a particular individual, of choice of eating more and walking less. We now understand it as a chronic disease, which is regulated by hormones within the hypothalamus, but also gut peptides, adipocytokines, overall modulated by environmental factors, behavioral and metabolic factors. It's a complex chronic disease. And with this understanding, our guidelines for management of obesity have also changed over time. And what used to be a predominantly a BMI-centric guideline has now moved on to what is more complication-centric. From India, we've had 2 major guidelines for obesity management by the Endocrine Society of India and the RSSDI, but it was just last week that we've also published an update of the Endocrine Society of India guidelines covering all the recent drugs that are available, but also something that we're really focused on is how to improve not the weight of the patient, but overall the quality of life of the patient, and that's what really matters. When we looked at our own data from the clinic that we have, the obesity clinic at CMC Vellore, we found that quality of life indeed is poor in most of our patients. But when we look at why is it poor, we see, aspects of comfort with dieting, the kind of experience that they fear with dieting. Sometimes if they've not really gone to a good specialist, diet would sometimes cause deprivation, make them feel frustrated, and a lot of problems if they've not gone through a proper channel of a good dietary counseling. So yes, Definitely, there is a need for newer anti-obesity medications. Lifestyle is the foundation. It remains the foundation throughout whatever therapy we follow, be it medication or surgery. But there are going to be more and more patients walking into our clinics asking for medications for obesity. So let's see what kind of medicines we've had in the past. And for a very long time, we really didn't have much in our armamentarium. Many drugs came and they went away with their side effects, with their black box warnings, and ultimately got banned. There were 5 USA approved drugs which were available, say about 5 to 6 years ago, of which many of them were not available in our part of the world, especially talking in terms of India. We had semaglutide, which was approved, but really not available until, say, 6 months ago. Liraglutide has been available in India and Sri Lanka, but it's not in the dose for what is approved for obesity management. Only 1.8 milligrams, which is used for diabetes, has been available. Orlistat, a drug neither the patient nor the doctor is comfortable prescribing given its side effects. But things changed when there was an US FDA approval which came in for semaglutide in 2021, and there has been no looking back after that. And today, when we look at the science of anti-obesity medications, most of the medications are predominantly targeting these 4 receptors: the GLP, the GIP, the amylin, and the glucagon. And in a snapshot, if you should see what kind of drugs that we have in the armamentarium, what is available and what is likely to be available very shortly in our markets, you see on the screen that these are the drugs of which now in India at least we have semaglutide and tirzepatide, which is available. I'm sure it would be available in Sri Lanka as well. Of all the other drugs, I'd see if it's the most powerful of them is the last one that you see in the obesity column, which is retatrutide, currently in phase 3 trials, causing weight loss to the scale of 25% and even more. So let's talk about 2 main drugs which are likely to be available very soon, especially because semaglutide is about to lose its patent in another 6 months. So the cost of that drug would come down significantly. Again, most of our patients would be able to afford once it's available here. So yes, semaglutide is a GLP-1 receptor agonist. A lot of actions across different organ systems in the body, but predominantly acting on the CNS, reducing appetite. The STEP 1 trial was the landmark trial which first time showed that a drug, which is if used in people without diabetes and just for an indication for obesity, could cause weight loss to the scale of 15%. And after STEP 1, there have been so many trials that have been published in the recent obesity guidelines from India. We've just summarized the efficacy, but by and large, 10 to 17% of weight loss has been seen by this drug in different populations in different studies. Not only for obesity, there has been also good impact of this drug with respect to cardiovascular system, and more recently data also for using an approval which has come for using in MASLD as well. So how do we use this drug? And very similar the way we've used it in clinical trials, we start slow and we gradually step up. We start this drug with a low dose of 0.25 milligrams given subcutaneously once a week. Gradually, after every month, we go up on the dose till the time we reach 2.4 milligrams once a week. Different types of pen devices are available, and though at present the cost is high, by March 2026, this drug goes off patent, and there are several companies which are coming up with generic models of these drugs. The trials of these generics with the innovator brands are already ongoing. So this is one drug that we might be able to use very soon for our patients here in Sri Lanka. But the other drug, which is again recently launched in India, has been available for a long time, is tirzepatide, which is GLP and a GIP agonist. Now, with the addition of this GIP agonist, in contrast with semaglutide, it gives a certain amount of benefits, especially in terms of the upper GI side effects. The nausea is in particular much less. The trials that have proven its efficacy in obesity are predominantly the SURMOUNT trials, and they've again shown how we have to start this drug very gradually, starting at a low dose of 2.5 milligrams once a week, and thereafter gradually stepping it up to 5, and then 7.5, 10, and ultimately moving up to 15 milligrams per week. The quantum of weight loss with this drug, for the first time, we've had an anti-obesity medication which has caused weight loss nearing sleeve gastrectomy, maybe 20, 22%. And again, this was the SURMOUNT-1 trial. There are 5 SURMOUNT trials which have been published more recently. This drug has also got an approval for usage in obstructive sleep apnea. There are trials ongoing with respect to the CV safety and also in terms of fatty liver disease. But a big question that often comes up when you prescribe these medications in clinical practice is, what about the side effects of these drugs? How many patients would actually discontinue these medications if they have been given? We've done most of these trials. I believe that many patients do have side effects, but at the same time, they do tolerate the medicine if given the proper advice that they have to follow. In this recent meta-analysis that we published, we looked at how we have to look at in terms of discontinuation rates or side effect profile. It is many a time comparable to the comparator arm that we give, but what is really important in clinical practice is just not to blindly prescribe the medication, but make sure you give the right kind of advice for diet, not only to reduce weight, but also a patient-specific diet to make sure what kind of side effects need to be mitigated for a given patient. Another very important aspect, especially in our part of the world, and I think 2 things, if I want to pick up from this guideline that was published: when you prescribe these medications in our population, make sure most of these patients take the adequate amount of protein that they have to, because these medicines, as I'll show you shortly, do cause muscle loss as well. And also, like in bariatric surgery, we give our patients a multivitamin tablet that needs to be taken lifelong. Similarly, many of these patients do develop these micronutrient deficiencies, which should also be corrected. Let's move on to the third aspect of this talk, talking about how these medicines also affect muscle mass. They reduce fat mass, no doubt, but they also affect muscle mass. And for that, a very brief glimpse of a body composition analysis that if we do with DEXA, what we've been doing for many years, if you look at papers on body composition, what's been followed is something which is a 2-compartment model. We as physicians have always been interested in fat, and everything else we've clubbed together as fat-free mass. But as we've got more and more innovation, better description of body composition, we've divided fat-free mass as that which is bone, and the remaining as lean mass further divided as the mass which is occupied by the organs, the water, and the skeletal muscle. And even in the skeletal muscle, we further divide that which is the appendicular skeletal mass versus the non-appendicular skeletal mass. Fat is also not uniform. Again, as we heard in the previous lecture, there is visceral fat and there is subcutaneous fat. And if, as a busy clinician, if I want to pick up 2 things most important in the body composition analysis for a patient, it would be the visceral fat and the appendicular lean mass by height square. But just let's focus on the muscle mass for a minute. When we look at data from these studies, and this is data from the STEP 1 trial looking at impact of injectable semaglutide 2.4 milligrams once a week, what is the impact on muscle? For every 10 kgs that my patient loses on this drug, 7 kgs is fat, but 3 kgs is also muscle. When you look at data from tirzepatide, the quantum of weight loss about 20 kilograms. How much of that is fat? About 15 kilograms is fat. This is data from the SURMOUNT-1 trial, and 5 kg is muscle. So yes, there is significant amount of muscle mass which is lost with these drugs. And if these patients gain weight, often the gain is just the fat and very few is the muscle. So it is very important for us as clinicians when we are prescribing these medications to also tell our patients what they have to do for their muscle strength. There are other studies. This is with Ozempic using 1 milligram of semaglutide, even the oral semaglutide Rybelsus, which has been available. The story is similar. By and large, a simple carry-home message would be for every 10 kg of weight loss, about 70% of it is fat loss and 30% is muscle loss. So why are we so worried about muscle loss? Well, we are worried because we know muscle loss is associated with not only falls, frailty, this cardiovascular impact, but what is really worrying is that when we look at longitudinal data of muscle mass and muscle loss, people who have low muscle mass or sarcopenia tend to have higher mortality, even as compared to people who have obesity. And if there is a combination of sarcopenia with obesity, and that is what most of our patients who are on these medicines would have, it is even more detrimental. Though we do not have direct data of how these medicines lead on to sarcopenia and what are their long-term complications, only time will tell. Nevertheless, I think it's prudent for us when we prescribe these medications to make sure we tell our patients about the importance of resistance training, which is very important in terms of building muscle mass. We heard a brilliant oration early this morning on how muscle strength is something which is very important and often a neglected area in our clinical practice where we don't talk about that to our patients. Also talking about low calorie, but good amount of protein in the diet. And also newer medications are coming up. There's a whole lot of literature now coming up with respect to how probiotics are also something which is very important for improving muscle mass. Amongst the newer medications, definitely calcium, vitamin D is important, but more recent data on myostatin inhibitors, this is a recent EMBRACE trial, which was published looking at how in patients who've been prescribed tirzepatide, if added another drug that improves muscle mass, can overall prevent the loss in muscle that happens. So with this, friends, I move on to the third aspect of my talk, which is talking about how do we initiate medications? Who should we give a prescription of these medications? Though many of these medicines do come with a BMI label, by and large in India, what is prescribed is a BMI of 30. And if the patient has comorbidities, a BMI of 27 plus comorbidities, you should be able to prescribe these drugs. But overall, global literature is now moving away from BMI. We're talking about looking at a patient with obesity beyond the lens of BMI and talking about staging systems of obesity. This is something that has been commonly accepted across the world, the Edmonton obesity staging system, which looks at assessing the patient with obesity, not just by weight, but trying to understand how the obesity stage can be very different. So what the staging system tells us is it looks at the medical, the psychological, and the functional aspect of a patient. If I have a patient coming to my OPD, maybe with a BMI of 35, but the patient comes and says, doctor, I have no issues with obesity. He has prediabetes, maybe all the other metabolic problems are normal. So I would stage that patient as stage 1. On the other hand, I may have a patient who's got much lower BMI, maybe a BMI of 29, but comes to my OPD on a wheelchair because she's developed severe osteoarthritis of the knee. And that patient would directly get a functional issue or a mechanical issue with obesity and go on to stage 3. And why the staging system is important is when we look at follow-up data from NAINS database, we see how the staging system can very clearly depict mortality as we look at these patients on a long term, which BMI cannot. Again, in our clinical practice, at least in Vellore, we've seen a large proportion of our patients do have Edmonton Obesity Stage System 2 and 3, and the Endocrine Society of India guidelines now very clearly tells us in which stage, what treatment to offer, and medications per se should be offered to patients with Edmonton Obesity Stage 2 and 3. Once we start these medications, these patients do need follow-up. Long-term follow-up, very similar to the way we start patients with diabetes medicines or blood pressure medications. They need follow-up periodically, and what is recommended, at least 3 monthly follow-up. And most of these patients need long-term medicines because evidence has shown if you stop these drugs, the weight gain happens to come back. Nevertheless, most of these drugs are very effective, and most patients in whom you start these drugs tend to lose significant amount of weight. What is also important for us as physicians is to look at what are the other drugs that the patient is taking, and if there are other drugs which increase weight, they also need to be changed for a given patient because you want to get the maximum impact in terms of weight loss with these medicines. With this, I move on to the last aspect of my talk, very briefly talking about the genetic aspect. And again, obesity has a certain amount of genetic predisposition, though a large proportion of it is polygenic. Again, something which is peculiar to our part of the world is a high degree of consanguinity that we see in some of our populations, and therefore the prevalence of monogenic causes of obesity, which is in literature said to be less than 1%, but many of our literature shows that in consanguineous populations, this type of obesity is more common. So when you suspect to have a genetic or a monogenic cause of obesity in clinical practice, when you have somebody who's got young onset severe obesity, family history of young onset severe obesity, hyperphagia, history of consanguinity, any two of these parameters which are mentioned globally, several papers there. We looked at our own data from Vellore. We found that about 18% of our patients meeting this criteria tend to have some of these mutations, MC4R mutation being the most common. And why I'm talking about it here is now we have newer drugs which are specific for these patients who have these mutations, and the quantum of weight loss that can be achieved with the help of these medicines is something which is huge. So friends, with this, I come to an end of my presentation. What I really wanted to highlight was that yes, obesity is a big problem, it's growing rapidly, and we all in our clinical practice will have more and more patients with obesity walking into our clinic. Diet and exercise is definitely important, is the first step, but many times patients do need medications as well. Overall, 4 broad receptors have been targeted for obesity management. The GLP and the GLP plus GIP receptor agonists are the drugs which are most likely to hit the Indian and the Sri Lankan market very soon. When we try and prescribe these medicines, they're very effective in terms of weight loss, but we have to guide the patient correctly with respect to their lifestyle and dietary practices so that we can prevent the muscle loss as well. And also, the indications of starting these drugs have to be just not BMI-centric, but looking at the patient overall as a whole is important. And last but not the least, in some patients, there is a role of doing a genetic testing because, again, there is a gene-specific drug which is also being made available. So with this, I'll stop, but would be happy to take any questions.
Thank you, Nitin. As always, he enlightened a nice lecture with the recent evidence as well as some practical aspect. But we'll keep question for the discussion session. So we'll invite our third speaker.
Yeah. I'm delighted to introduce our last speaker, Dr. Dilendra Weerasinghe. He's a board-certified general bariatric and gastrointestinal surgeon with advanced training in minimally invasive and robotic surgery. Currently serving as Director of Bariatric Surgery at Rochester Regional Health. Notably, he has performed over 1,500 robotic procedures and mentors upcoming robotic surgeons. Dr. Dilendra is going to talk about optimizing outcomes of metabolic bariatric surgery to the right patient at the right time. Over to you, Dr. Dilendra Weerasinghe.
Thank you, Prasad and the college for inviting me. It's a pleasure to be here at this conference. I do have relevant disclosures other than the fact that I'm a surgeon. I do have financial ties with Medtronic, Intuitive, and Cambridge Medical Research, which I've received via the consultancy, proctoring, or mentoring. We all know that obesity and diabetes goes hand in hand, and the incidence has been rising over the years. And what I'm trying to elaborate as my talk goes on is the close relationship between insulin resistance and obesity, and how bariatric surgery, through the concept of what we believe to be nutrient-stimulated hormonal activation, can help achieve tremendous results in this front. So the father who brought about the concept of metabolic syndrome and insulin resistance is this man, Gerald Raven, who for the first time talked about insulin resistance in humans and proposed that those who have truncal distribution of fat, the visceral obesity, diabetes, hypertension, triglycerides, hypertriglyceridemia have a common etiology in insulin resistance and impaired glucose tolerance. So with the advent of novel therapies like GLP-1, like my previous colleague had mentioned, the American Heart Association and the Kidney Association have now brought about the concept of CKMH, which is cardiovascular kidney metabolic health. So this is all to do with the insulin receptor. There is no problem with the insulin binding onto the receptor, but the downstream signaling after the insulin receptor binds is in some way faulty, which leads to the insertion of the GLUT4 receptors. So when you have insulin resistance at the center and core, you have the manifestations of clinical disease in the form of atherosclerotic disease, type 2 diabetes, PCOS, hypertension, so the whole gamut of disease, including MAFLD, centers around insulin resistance. So for the run-of-the-mill obesity, which is polygenic, has a significant component of insulin resistance. As the talk unfolds, I would also try to emphasize the role of hyperglycemia and hyperinsulinemia. Unfortunately, most of the physicians do not test insulin. So therefore, you may have normal blood sugars, you may have normal A1Cs, but when you do a fasting insulin level, you'll find that these patients are hyperinsulinemic. And when it comes to treating diabetes, it is important to not only remember the consequences of hyperglycemia, but you need to address the hyperinsulinemia as well. So if you, as a physician or an endocrinologist, has a wonderful A1C of 6.5 with 300 units of insulin on board, I'm not sure whether you're doing a really good job for your patient. It'll really look good for you to have brought that A1C from 10 to 6.5, but if you're giving very large amounts of insulin, you may be potentially causing harm for the patient in other ways, like increasing atherosclerotic disease or heart failure. So the concept of CKMH, which has been brought about by the American Heart Association, is really dealing with this and trying to use guideline-directed medical treatments for metabolic disease, as it has profound impacts on chronic kidney disease, the cardiovascular system, leading to multi-organ dysfunction. So CKMH0 which is a healthy person. Very briefly, to progress, CKMH stage 1 is when you have a dysfunctional adipocyte. Mainly, we're dealing with fat cell hypertrophy. So when you have hypertrophy of the fat cell mass, those fat cells break down, releasing interleukin-1, TNF-alpha, and pro-inflammatory mediators, which can in turn lead to increase in the levels of free fatty acids, leading to fatty liver and metabolic syndrome. So stage 2 is when you have metabolic syndrome, and stage 3 is basically subclinical atherosclerotic vascular disease and subclinical heart failure. And stage 4 is full-blown peripheral arterial disease, stroke, heart failure, and coronary artery disease with atrial fibrillation. So the importance of this is that if you have high BMIs, you have a lower survival. If anyone has a BMI 40 and more, there's on average 10-year reduction in lifespan. Add diabetes to that, make it 13 to 14 years. If you add kidney disease, CKD stage 4 plus, you are looking at 20-year shorter lifespan. So it's very, very important for us to identify these patients at risk and start a guideline-directed medical therapies, which may include not only the use of GLP-1 medication, but at certain points, bariatric surgery. So that takes us to the next part of the talk, which is the ominous octet. I think our previous speakers alluded to the triumvirate, which is basically a dysfunctional pancreas, a liver, and the adipose tissue. But in 2009, on the Banting lecture, Dr. Ralph DeFronzo introduced this concept of the ominous octet. In addition to the liver, pancreas, and the adipose tissue, there are dysfunctions in other organs, to include problems with the kidney. We know that in obese individuals who are insulin resistant, there's increase in SLGT2 receptors, leading to reduced clearance of blood sugar. You have a dysfunction in alpha cells, which leads to increased production of glucagon. There's problems not only with the incretin secretion, as well as the neurotransmitter secretion in the brain, as well as the way we see food. So when you're insulin resistant, the way we see food changes as well. We have a craving towards the high fat, high caloric, and high sugar foods as well. So understanding the ominous octet and its role in hyperglycemia also helps us manage these patients. Now, we always talk of BMI, but this is a very interesting slide which basically shows that not always BMI is associated with ill health. If you look on the extreme right of the screen, the Federated State of Micronesia has an obesity rate of around 75%, but their diabetes rate is similar to that of Bangladesh, 5% diabetes. Yes, they are fat, but no, they are not sick. Now, if you take, for that matter, the SAARC countries like Sri Lanka, Singapore, Pakistan, Afghanistan, Bangladesh, Myanmar, those countries have a very low incidence of obesity, but a disproportionately much higher number of diabetes and metabolic disease. And when one ponders as to why this is, it goes back to what our previous speakers had spoken of. This is actually a medical term, thin on the outside, fat in the inside, all to do with the visceral versus subcutaneous tissue. So out of the two, whom do you think is the sicker one, the one on the right or one on the left? Whoever who thinks the person on the left is healthy, can you raise your hands? The one on the left? The one on the right? It's like almost 50-50. If you really look at the unhealthy one, is the one on the right. They have less fat overall, but if you look at the ratios, they have nearly 4 times the visceral fat as compared with the subcutaneous tissue. So this is why, with a lower BMI, you have much higher incidence of metabolic disease. We talked of the lipodystrophies, the partial lipodystrophies. They have skinny legs, big bellies, a lot of visceral adiposities, and they're really sick. The exact opposite of that trait are the little women of LOHA. They have an insulin growth hormone deficiency, IGF-1 deficiency, which leads them to be obese, but they have no cancer, they have no diabetes, perfect triglycerides, and they live longer than their counterparts who don't have that mutation. So, progressing along, one of the reasons why the Asian subcontinent may be having this problem may be because of PNPLA3 mutation in the liver, which may drive a fatty liver disease. Now, how does bariatric surgery, Ranil, can I have a glass? Yeah. So how does bariatric surgery play, and why is a bariatric surgeon here talking to you today? And this is to do with, we had one of our speakers talk of GLP-1, another speaker spoke of FGF21, and due to the alteration of the nutrient flow to the hindgut and the incretin effect, we have similar changes which help with insulin sensitivity. So this concept is called nutrient-stimulated hormonal activation. When you eat, the food goes very fast into the distal hindgut, activating GLP-1, GIP, peptide YY, and many other incretins to help not only with insulin secretion, sensitivity, uptake, as well as other compounds like FGF19 and 21, which improve the fatty liver, as well as fat cell transformation from browning of, or what is called browning of adipose tissue. Not only does it have an incretin-based effect, it also affects our brain, and it takes away some of the symptoms of obesity, like hunger, craving, the feeling of satiety, which is lost in obesity and in insulin-resistant states. Now, there are 12 randomized controlled clinical trials looking at the superiority of bariatric surgery versus best medical therapy for diabetes, and you can see almost all of those trials except one trial with a lap band showed statistically significant benefit, proving the fact that any surgery which is metabolic would help with the resolution of metabolic disease. The lap band is putting a ring around the stomach, so it is not a metabolic operation. Therefore, you don't have superiority in diabetic control, because the only way that you will get benefit is with weight loss. What we're talking of in terms of nutrient-stimulated hormonal activation is that those are independent of weight loss. You will see glycemic control improving immediately before the patient gets home within a day or two of their surgery. And the profound impact of GLP-1 not only goes to just glycemic control, but it also helps with the heart. So we have a very robust heart failure program, and it's amazing that some of our patients who are on impellers, who are on left ventricular assist devices, get referred for bariatric surgery on an emergent basis, and once we do the surgery, within 2 weeks, they're off their assist device. So the profound role of insulin resistant, not only on atherosclerotic disease, diabetes, but also on the short-term function of your heart also is very, very dramatic. You don't need to wait for the weight loss to see how the myocardium responds. It happens almost immediately. Heart failure is also an insulin-resistant state. Do any of you know that in the last 50 years, how many drugs have been specially designed for heart failure? Tell me one drug which has been designed for heart failure. Sorry? Oh, okay. Well, I mean, that's the ARNI, yes, I would admit, but out of the many other drugs, there has been no drugs really. Beta blockers for hypertension, atrial fibrillation. The main drugs, SGLT2 inhibitors for diabetes, it was actually thrown away from diabetes, picked up by the heart failure specialists. The ARNI actually goes into neprilysin, and that's the only thing which has really benefited the heart failure and been kind of specifically found for heart failure. But the majority of drugs have been from the field of diabetes or hypertension. So let's look at some of the data which is available. Let's look at GLP-1 data. This is, I won't dwell too much time because our speaker has spoken on that. But on the SELECT trial, it showed around 20% improvement in composite 3-point MACE, right? But the study, even though it had 17,000 patients, was not powered enough to show the endpoints for heart failure, death from any cause, or cardiovascular events, but their primary goals were found. But this is an interesting study. It's a retrospective study. It's not a prospective randomized controlled clinical trial, but this is from the Cleveland Clinic, where they looked at nearly 2,300 patients and matched them with nearly 12,500 patients, 12,000 patients for age, BMI, comorbidities, and looked at the same thing. The 6 and the 3-point MACE, you see, for the primary composite, which is 6-point MACE, 3-point MACE, there was a 40% risk reduction, and similar for the secondary MACE as well. And if you look at all-cause mortality, heart failure, coronary artery disease, CV, cerebrovascular disease, nephropathy, and atrial fibrillation, again, very, very profound changes, anywhere between 40 to 60%. Yes, nephropathy or CKD can be reversed with bariatric surgery as well. So you can change and reverse, and we can get into the pathophysiology as to how that happens as well. Now, if you look at the side-by-side comparisons, medication versus surgery, as you can see, there's around 2-point drop in A1C, and you can see around 10-15% weight loss with the semaglutide. But you can look at bariatric surgery, over 8 to 10 years, sustained 25 to 30% weight loss, as well as glycemic numbers dropping more than 3 points. So bariatric surgery is an extremely powerful tool. Now, the speaker also spoke of GLP-1s. Most of the weight loss trials are for 1 year. And when you discontinue the medication, within a year, your weight gains. And the concern is that the 50% of the muscle mass loss is now being replaced by fat mass. So long-term studies are yet awaited. We don't know what the long-term implications of GLP-1 medications are. Now the question is bariatric surgery safe? most of you physicians believe that bariatric surgery is not the safest because you've heard of horror stories of bariatric surgery going bad. And that's a general perception in the community. But let's talk about real data and facts. If you look at the morbidity, cabbage has, if you have a coronary artery bypass graft, you have around 45% morbidity. Now, the bariatric surgeries, the gastric bypass, has 3.4. It's even lower than that for a laparoscopic cholecystectomy. If you take a look at the mortality, it's less than that for a laparoscopic appendectomy and a lap chole. So bariatric surgery is extremely safe and it's extremely effective. This is a very quick show of a procedure called a duodenal switch. If you do a duodenal switch on a patient, even if their A1C is 13, and as long as they have a C-peptide of more than 1, we can guarantee you long-term remission of diabetes in the rate of 90%. So this is done with robotic assistance. If you guys can play the video, please. This is a quick video to show you, and we will fast forward from time to time so that you understand it's not as bad. This is not gory surgery. We do this with robotic assistance, and here you will see the first part of this surgery is doing a sleeve gastrectomy. That's the commonest procedure which is done. We quickly enter into the lesser sac of the stomach, taking down the gastrocolic ligaments, 10 times visualization with the robot, and dexterity and absolute precision. So making surgery so much easy. Anyone can do this type of, given the proper training, a medical doctor can sit down at this console and do this surgery yourself. We can go, let me see, we'll jump a little bit in front. Here's the duodenum coming into play. The pancreas is right there, your good old friend, and you can see it's a little bit yellow. That's called fatty pancreas as well. So not only do you have fatty liver, it ends up with being a fatty pancreas as well. So the duodenum is being dissected very easily. A lot of the time, surgeons are scared to venture into the duodenum, but this is not that difficult, even laparoscopically, but robotically, it's so much easier. Just doing the duodenal dissection just to get 4 centimeters of the duodenum. And this was actually done for a different talk because it was a hybrid technique that I was promoting in Oxford, but I thought this might be useful for you guys to see as well. And that's the entire duodenum. The gastroduodenal artery is here, so that is our end landmark, giving us 3 to 4 centimeters. And now we are marking the transection. So the duodenal switch, part of that, the first part would be a sleeve gastrectomy, marking the transection site. And and we change. And even though you can staple robotically, this is a hybrid technique, so I use a manual stapler to come back in and start stapling the stomach. And you can see, again, the staple line is so beautifully hemostatic, there's not a drop of blood. If you have that gauze at the back being soaked, that's 5 cc or 5 milliliters of blood. So the blood loss for this procedure is like in 1 or 2 milliliters. Patients go home with a duodenal switch, which is the most extensive operation that we do in one day. That is the following morning. If they have a gastric bypass or a sleeve gastrectomy only, 50% of our patients go home the same day. So again, surgery is extremely safe, and we'll just show you the suturing part again on the robotic platform. It becomes so much more simpler. Very quickly, a few sutures, and you can see the ease by which you can do the surgery using a robotic platform. How many minutes do I have? Oh, 2 minutes, yeah. All right. Can you go to the next slide, please? So when you have a patient with metabolic disease, stop and think for a moment. Am I doing the right thing by the patient when I'm just trying to target A1Cs? How do I basically change and influence the care for this patient? Do you have really time to talk to the patient about the proper diet, the need for exercise, how to change their behaviors, how to look at even their past adverse childhood experiences, which may make them want to be obese in a subconscious way? How do we include the cardiologist, nephrologist, the gastroenterologist, as a team to help address the metabolic mayhem which is happening, controlling glycemia whilst protecting the end organs? Remember that surgeons also may have tools. I know for a fact that there are 2 surgeons in this country who offer bariatric metabolic surgery. If your patient is obese, having metabolic dysfunction, and they're resistant to your primary therapies for diabetes, is it time for you to talk to them and see? It's not a question whether surgery or medications are better. We welcome the fact that there are effective medications out there to treat not only obesity but diabetes, but we have to try to put the patient at the center, using each other's expertise to help treat our patients in a unified, patient-centric, evidence-based fashion without holding our bias against coming in for evidence-based treatment of our patients. After all, we all went into medicine to heal and comfort, and so we became doctors. Remember that your surgeon is not as dumb as you think he is. With those words, I'll end my talk.
Thank you very much, Dr. Dilendra Weerasinghe, for the excellent talk. Pharmacotherapy, unlike pharmacotherapy, the metabolic surgery offers long-lasting effect on diabetes, obesity, and insulin resistance. You emphasize the importance of integrating specialized knowledge to give a safest outcome. Now I would like to invite all 3 speakers to the stage, and Professor Ranil will introduce the panelists for the panel discussion.
Thank you. And so we have a very distinguished panelists here for the covering all part of the obesity region, including nutrition and the endocrinology and the surgery. And those are leading Sri Lankan experts. Surely they have questions to ask from the international speakers, as well as you also can ask questions at the end. So first panelist is Professor Thejana Wijeratne. He's well known to all of us. He's like a pioneer of doing a bariatric surgery in this country. And what do you say? Please come. And second panelist is Dr. Jayani Thennakoon, and she's a consultant nutrition physician for the Columbus South Teaching Hospital, Kalubowila. The last one is the consultant endocrinologist, Dr. Dulani Kottahachchi from the Department of Physiology, Faculty of Medicine, Ragama.
Yeah, to begin the discussion, Dr. Nitin Kapoor explained in very detail about the pharmacotherapy, especially the incretin-based therapies. I would like to ask, as in a nutritionist aspect, Dr. Jayani, what would you suggest or recommend in a patient who is already on incretin-based therapy? Is there any difference or suggestion you would recommend based on meal timing or snacking? What would you advise?
Yes, so thank you very much for that question. And I think Dr. Nitin highlighted very importantly how important the diet and the exercises is, because any mode of, I would start by saying, like any mode of weight loss therapy, would have a percentage of muscle loss unless you balance it with the proper diet and the exercises. So what we forget is we always talk about weight loss, but we forget about the part of the weight maintenance, which is much more important. So that is where we get into the diet plan, basically. And generally, if I speak, we always try to look for very shortcuts and try to go for very extreme diet patterns, which we cannot hold up for a long time. So as a patient on a pharmacotherapeutic agent also, or as if the patient is on a lifestyle modification, I would say it's not a magic diet that the patient is on, but basically a low-calorie diet to balance the patient's nutrition needs, but a mixed meal pattern where it is distributed with the proper timings, because extreme, exceptional long hours of not eating will not matter, especially the timings that the patient is active. As a vehicle needs the fuel, we need the fuel also at the proper timings. And again, I would highlight the balance part, the energy, the protein, and of course the high fiber and the vitamin and mineral composition with the vegetables and the fruits. So that is how I would prescribe the patients, and would highlight that this is not an exceptional one where this individual who's on the medicine should be on this diet, but it's basically the family diet that you would adjust the portion sizes and give the patient the confidence, okay, you can enjoy, but just how you serve your plate is how you advise the patient. So, and also combining the necessary exercises is very, very important, because not just the diet, you give the protein, but if your muscles properly not used, of course you will not get the muscle strengthening. So both things we tend to highlight. So I hope I answered your question.
Probably our Sri Lankan panelists have some questions to ask from the international speakers. These direct questions to clarify from the.
Yes. Well, one of the key things that was highlighted by my surgical colleague is that we no longer look at recognizing, we no longer try to push bariatric surgery unnecessarily where the medication might help. On the other hand, we will not hesitate to go in for bariatric surgery where the medications does not help. But you see, Harinder, can you just tell me whether there are any guidelines or actually proposals by the American Society of Gastroenterology or the American Cardiovascular Association or the Diabetic Association with regard to on what parameters should you prescribe somebody to the new GLP-1 or the GLP-GIP combination drugs, or straight away to bariatric metabolic surgery?
Yeah, thank you for that question, Thejana. I think that's an excellent question. And this is the reason why right now the guidelines are all convoluted. So clearly, if you have diabetes, there's no question GLP-1s are there. Right now, the recommendations are that if you have a BMI, the recommendations by the Obesity Society is that if you have a BMI of 30, then without comorbidities, you can start a GLP-1, which is slightly different to the Indian recommendations. But from an insurance standpoint, now they have pushed that to the old 1991 NIH consensus guidelines, which is 35. The insurances are pushing back. And the reason for that is the prohibitive costs. So really, when you look at the Kaiser Permanente data, where they really, as well as Blue Cross Blue Shield data, at the existing prices, you can do 10 bariatric surgeries for the same value of GLP-1 medication. And even if you have free access to GLP-1 medication, now they didn't really look at the real causes, the exact causes, but on the Blue Cross Blue Shield main insurance database, 50% of the patients who were on a GLP-1 gave up that GLP-1. So the answer to your question is the CKMH, which is coming up from the American Heart Association with 5 centers already having been recruited, will be a guideline-directed algorithm for the use of GLP-1s in those patients when they fail, what the next steps are. We in our hospital have started something very similar, giving the choice to the patients at the front end. Do you want to be on a GLP-1? You have your CKMH stage 2. You deserve to be on a GLP-1 or have surgery. What do you want to do? You can choose to be on neither. You don't want GLP-1s? You don't, because you get severe heartburn, reflux, nausea. I don't want to have surgery. So that's your choice. Some may say, let me try a GLP-1. The most effective thing would be to start with a medication. If there is a problem, then convert to surgery. But there's a problem to that. There's emerging evidence to support that when you start a patient on a GLP-1, your body starts adapting. And now with like GLP-1, there's GLP-2 in your body. So GLP-2 increases the villous mucosal surface area by causing villous hyperplasia and increasing food absorption. So this is why people on long-term GLP-1 medication may have issues with weight gain, but they will still have maintenance of improvement from a MACE standpoint.
Thank you. Actually, I have a question for the Fredrik. I know what you shared was very high technology thing, and which are using isotopes and measuring the body composition, and was very difficult in this kind of area. In this region, in the South Asian region. So, have you any validated BI or bilateral impedance or skin fold thickness or something, some easy method to distinguish upper body fat mass and lower body fat mass? Not a very expensive isotopes methods.
Thank you. I think there were a couple of questions here. I think my favorite way of characterizing body composition is actually the DEXA scan. It has a good algorithm for visceral fat. It gives you muscle mass, lean body mass. It gives you upper and lower body subcutaneous fat. It's a very versatile and low-cost characterization. You asked about the stable isotope measurements, and what that gives beyond many other things is a metabolic flux. And we talk here about GLP-1s, bariatric surgery, insulin resistance, but we are actually focusing on metabolic flux. And the other things are just words, but emptying the fat out of the muscle, out of the liver, that makes patients healthy in weight loss. It's not the actual loss of adipose tissue, it's the taking the fat out from the wrong place that helps people.
One last question. Do you have any data on the South Asians, because they have a different body shape?
I think to cut a very long story short, I think characteristic of the South Asian phenotype is insufficient subcutaneous fat storage that pushes fat into places where it shouldn't be. And toffee, you also talk about toffee, fat on the inside, lean on the outside, and that's exactly what it is. You don't see the fat on the subcutaneous where it should be.
So we'll question
from you. Can I quickly ask you about PPAR gamma agonists like pioglitazone, rosiglitazone? That has a fat distribution change, a net fat gain, but it also has insulin sensitizing action. So can you, either one of you, comment on that?
I'll have a quick try here. So PPAR gamma agonists are not useful drugs for this purpose any longer because you put on weight. But they are insulin sensitizers. They affect the bone in a harmful way, so long term it's not sustainable. But the principle is there. The principle that you actually promote fat storage and drive fat away from the liver and the muscle. And that's what these drugs are doing. But they're doing so many other things that are harmful, so not useful in the long term.
Completely agree. Yeah.
Can I ask Prof. Nitin, when we start on a lot of patients on incretin therapy, the semaglutide and the tirzepatide, there's a lot of discontinuation as we also see. What are the things you think why these patients lose interest in these medications, or what are side effects? Why are the reasons for this discontinuation of treatment?
Right, so I think that's very important. Discontinuation is a problem that we see with these drugs. But again, I would say that from our experience in clinical trials with these drugs, it's kind of idiosyncratic. Some patients who just don't respond from day one, they are just having a lot of side effects and they wouldn't just take it, whereas others may be able to tolerate even bigger doses. We did the Pioneer plus the OSS trial, 50 milligrams of oral semaglutide, I mean, they could tolerate. Having said that, some patients in the intermediate who would be having some side effects, I think the mantra is to go slow. Just no need to jump up from a lower dose to a higher dose just because 4 weeks are over. Some patients need another 4 weeks. And plus the dietary aspects, very, very important. The difference between Asians and Caucasians, we haven't done any studies as such, but definitely we've been part of those big trials, and I think the rates are similar.
Probably because of interest of time, we had to close the discussion. But sure, your speakers will be around, so if you have questions, you can meet them and talk to them during lunchtime. So we'll hand out token of certificates for the speakers first.
You have them.
Professor Fredrik.
And Dr. Nitin Kumar. Okay, sure. And Dilendra. So you will get some gift also.
Now I'd like to invite Professor Ranil to hand over the tokens of certificates for the panelists. Professor Thejana. Dr. Jayani Thennakoon and Dr. Dulani Kottahachchi. Thank you very much for all your participation.
There was a mistake from our side in the panelist flyer. Apologies for that. And also, I would like to invite Dr. Ushani Peruma to award the certificates and letters of appreciation to our chairpersons.